Hi, I'm Andy Vasey at UNMC Nebraska Medicine, talking about post-acute COVID syndrome today. So our objective today, talk about post-acute COVID syndrome here in Nebraska, the efforts that we have at UNMC Nebraska Medicine, talk about the multi-system presentation and workup of these patients, and also the role of interdisciplinary care for people with post-COVID issues. So to start off and have a patient presentation. So saw a 32-year-old gentleman with no past medical history in the post-acute COVID clinic here, who was diagnosed with COVID back in November of 2020. Initial symptoms were fevers, chills, aches and pains, diarrhea, nausea, extreme fatigue, shortness of breath, and just not quite thinking clearly. Went to his local emergency department for these issues. Part of the workup, got a CT scan, showed he had ground glass opacities kind of bilaterally. Got admitted to the hospital there for a few days. Never required oxygen, didn't get any specific treatments like remdesivir or steroids. Was starting to feel better and was discharged about 2 days in. For the first week post-discharge, things seemed to be improving. About 2 weeks in, started having more and more issues. Started having issues with his heart racing, getting lightheaded with minimal activity. Previously had been a runner, now walking around the house, he would get short of breath. Also started having some allergy type issues, started having rashes, kind of quite a bit of diffuse itching, certain foods causing some more upset stomach and diarrhea. We'll get back to this gentleman here later in the presentation today. So a little background information with COVID-19 here in Nebraska. As of the end of September, these are some of the numbers I was able to pull up. So Douglas County, we've had about a little over 83,000 cases of COVID, just under 800 deaths. Lancaster County and Lincoln, 40,000 cases, about 290 deaths. In Hall County out in central Nebraska, 9,400 cases and about 120 deaths here. So this just shows that the vast majority of people who get COVID infections survive. The majority of these people go back to their normal functioning. Anywhere from 20 to 30% of the people deal with post-COVID issues. So with post-acute COVID syndrome, we know that we don't necessarily know a whole lot. Things seem to change daily. From a study standpoint, definitely understudied. The NIH is in the process of starting up a trial looking at post-acute COVID called Recover study. That's something that's going to look at that and hopefully give us some more information on that. The CDC itself defines post-acute COVID as having symptoms 4 weeks after having your initial COVID infection. Various places define this differently. For the criteria for our clinic is we have 8 weeks of symptoms. So again, it varies a little bit as to what they say, what exactly is post-COVID. The other issue is, what do you call it? Well, people call it a lot of different things. So it can be called long COVID, long haulers, long hauler COVID. Post-acute sequelae of COVID, that's the NIH preferred name, or PASC. Post-acute COVID, post-COVID, chronic COVID. There's still other ways people refer to this. So as for symptoms of post-COVID, so the initial symptoms or reports out there in the literature actually didn't come from medical professionals. It came from groups of patients that got together that surveyed other people who had COVID infections and put out a publication saying these are the most common symptoms people have with post-COVID symptoms. They actually preferred calling this COVID long haul or long haul COVID, and they are the ones that actually kind of coined that term of things. So the symptoms: shortness of breath, chest tightness, fatigue, chills, continued cough, elevated temperature, headache, and brain fog. Now, various publications that came out after this was May of 2020, all the other publications that came out from various places, whether the US, Italy, other countries, really kind of had the same type of symptoms that were reported the most commonly after that. So post-acute COVID, why does it happen? We don't know for sure. Some of the thoughts would be you get a COVID infection, you have direct injury to that organ and thus have those issues related to that. Another thought is you get the COVID infection, you get some autoimmunity generated, then you attack various parts of your body from that standpoint. Another thought is people have prolonged viremia, or they have COVID pockets or reservoirs of COVID that get released over time and cause some of these breakthrough infections. So this kind of takes into account people that have the waxing and waning of symptoms, where they'll be more towards normal for a while and then they'll have worsening of their symptoms, get better, get worse. Another one is mast cell activation. So people have their mast cells inappropriately get activated and release extra histamine, and that causes a lot of the different symptoms that people can have post-COVID. What's the right answer to this? Nobody knows. When you look at people who present, some people kind of fit into one bucket or maybe another. Again, potentially it's a combination of things or different for different people. So to turn now a little bit to what we're doing here at Nebraska Medicine with our post-acute COVID clinic, talk a little bit about how it came to be. So back about a year ago, a group got together to talk about the issues that we were starting to see. People who had COVID infections had continued issues. At that time, there were a handful of programs around the country that were starting up post-COVID clinics. University of Pennsylvania was early on, University of California, Davis, a lot of different places around the country were starting to look into that. So the group, we got a large group together to talk about this issue. So it wasn't just one person that said, hey, I'm going to do a post-COVID clinic, but we got buy-in from a lot of different subspecialties, not just internal medicine, but some of the other specialties around. So cardiology, pulmonary, ID, neurology, physiatry, along with psychiatry and behavioral health. So we had multiple people from these areas get together, talk about what's kind of been seen in their areas and what can we do about this and how do we exactly go about doing it. So one question that we had initially was, do we have everything centralized or do we not? Thinking from a standpoint of patient-centered medical home, it'd be nice to have everything in one stop. But thinking through things, not everybody needs to see a cardiologist or a physiatrist or whoever the case may be. So our thought was to say, well, we're going to start doing this in a decentralized fashion because not everybody needed to see a cardiologist. Our thought was to have it run through primary care, and by primary care, that was me to start. So my goal was to start seeing these people, see how the process went, try to work out referral patterns or referral networks, and then open it up with other providers here. So again, the biggest kind of stretch was clinic availability. So most people have full clinics the way that it is. How do we get these people in to see different providers? So to start, we didn't open it up just to the general public. So talking to a lot of other facilities that had done this, so Cleveland Clinic, who went before us, UT Southwestern, they opened it up just to anybody who wanted to be seen or needed to be seen. They were completely overwhelmed by the amount of people that needed care. So we decided to open it up on a smaller scale to work out some of the issues that we figured we would see as we did this. So we first started it to Nebraska Medicine and UNMC employees and their families. After that initial start of things, we opened it up to anybody who was seen at Nebraska Medicine. And we're getting closer to the point of opening it up just to anybody who wants to be seen, whether referred or not. We're in the process of recruiting more physicians to work with the kind of intake of this. Right now, there's myself and 2 other med-peds providers that are seeing patients, opening it up to a few more providers after that. So post-COVID care. Well, how do we navigate things? So cardiology and both pulmonary started doing post-COVID clinics roughly about a year ago. Cardiology really started it more so from the standpoint of return to play, so kind of younger athletes who have had COVID infection, or can they safely go back to their sport of whichever sport that may be. Pulmonary started a few months after that for a lot of these people who were in the ICU, who were very sick, who were oxygen dependent and needed care outside of the hospital. Now, what we found is a lot of these people that got sent to these, whether cardiology or pulmonary clinic, really didn't have issues that were in those specialist area of expertise. So people that were having more brain fog and fatigue were being sent to pulmonary because the provider didn't know who exactly were seeing patients, and they sent them there because it said post-COVID clinic in the clinic name. So really not the best use of a pulmonologist or a cardiologist's time to deal with issues such as neurologic issues or psychiatric issues. So our goal was to really, like I said, funnel this through primary care. So the initial visit, the goal of the initial visit was really to find out what's going on with these people. So you'd hear a few things from sometimes with the referrals, you'll get some paperwork, but really kind of getting down to the heart of what's going on with these patients here. The other thing is saying, well, what's been done and what else needs to be done. So Mayo, for example, their post-COVID clinic, the Mayo way is they do all the testing up front, and then they meet with the patient and then go over what's abnormal, what's not abnormal. Trying to be financial stewards, that's not really a cost-efficient way of doing things. A lot of these patients have had issues working, so finances are definitely an issue there. So racking up a bigger medical bill, really not probably in their best interest of things. So our goal is to say, well, what kind of things do we need to do to further, take care of this patient? Are there other conditions going on that we can intervene upon? So as everybody knows, from post-COVID symptoms, there's no specific treatment for that. We treat a lot of different symptoms of things. So is there something going on? So some people might have some interstitial lung disease related to this. They might have some myocardial involvement. So trying to find these things out and treat those appropriately is very important. So the referrals then, that was kind of the next step, is saying, well, do they need to see a pulmonologist or cardiologist or whoever that may be? So that was kind of the next step for us to do, is say who needs to see who, and really being able to get them in a reasonable time frame. So you look at some referrals, as everybody knows, you try to refer somebody to somebody, it takes 3 months to get in there. Well, that's kind of tough when you're trying to figure out what's going on with this person to try to get them the care that they need. So we really worked on trying to get an internal referral network where people could be seen in a little more timely fashion. And again, having, say, cardiology and pulmonary, which were some of the more common referrals, having their own specific post-COVID clinics was a helpful thing for that standpoint. Another thing we kind of discussed early on is saying, do we see these people once from an internal medicine standpoint, have them go see a subspecialist, and have them just go back to their primary? Or do we have them follow back up with, say, me, for example, and try to kind of really put everything together for the patient? So our thought was saying it was probably better to have them have at least a follow-up or two after the fact, whether that be in person, telehealth, or even through portal message. We thought that was going to be an important thing here. So not just putting this all back on to a primary who might be somewhere else who doesn't have access to all the information that was done. So what are the things that we've seen here in our post-COVID clinic here? So one of the most common things we see are people with pulmonary complaints. So shortness of breath, whether that's with exertion or at rest, cough, some oxygen dependence. And now pulmonary, they've seen a lot more people that were just, sent from various places that were, ICU type patients that were sent after the fact there. We've seen a few people in our clinic that are still on oxygen. The vast majority of people that we've seen have been people that have been moderately sick at best. I think I've seen 2 people that had been hospitalized in total, 1 person that was in the ICU. But the rest of these people were sick, really, though they didn't, seek a whole lot of care at the time, or if they did, they were given symptomatic care. So another kind of thing, whether related to pulmonary issues, fatigue or not, kind of thinking, sleep apnea. So common things being common, sleep apnea is a very common thing. It's one of the things I've probably found the most in these people in the testing that I've done. So of the testing I've done from a pulmonary standpoint, the most common tests I've gotten are PFTs or sleep studies. So PFTs kind of vary as to what we see. Most times they're normal. There are times that you can see some reactive airway disease, so kind of an asthma type picture, or probably the most common in the PFTs are decreased diffusion capacity. Now, what's the significance of that? Well, I really don't know. The one thing with that is if you have an abnormal pulmonary function test, it makes it a lot easier to get a person a CT scan, seeing do they have some sort of structural disease. For the people who happen to have had imaging when they were first ill, so they went to the ER, got X-rays, CTs, a little easier to get things approved there if they have abnormalities then. So if they had an abnormal CT with ground glass opacities, they're still short of breath, a little easier to argue that with insurance to say, well, we need to do a CT now. I found that if a person does have abnormal PFTs, a lot easier to get the CT though. Again, sleep study, another thing that's shown a lot of positive results from, that a lot of people have sleep apnea, probably more so than I've seen in my own clinic population of things. Most of these have been home sleep studies. Now a lot of insurers are going back to their pre-pandemic rules of saying people have to have in-lab studies, but for the vast majority of people, the home sleep studies work really just as well. So as I kind of mentioned before, the most common thing I see, decreased DLCOs. Some people you'll see a little bit of blunting of their graphs that show kind of vocal cord dysfunction, so kind of an extrathoracic obstruction of things. And then with the imaging, most times normal, but sometimes you'll see some ground glass opacities persist. Another very common thing we see here is people with cardiac type complaints, so people with chest pain, shortness of breath, whether rest or activity, a lot of the kind of autonomic dysfunction, tachyarrhythmia type things. Most common things we do there: EKGs, Holter monitors, potentially echoes, potentially troponins and stress tests as well. So a lot of the people that I've seen in the post-COVID clinic actually already saw cardiology before me. So a lot of the people I've seen already had a lot of these things done. Now, for the people I've seen that haven't seen cardiology, do I do all these tests? Well, maybe, maybe not. Cardiology will do a lot of cardiac MRIs on these people too, getting a better picture of their myocardium. That's a test that I can say I've never ordered, and really don't see myself ordering that one per se. I think that having a cardiologist be the one in charge of that probably is a reasonable approach of things. So the kind of different things that we've seen, a lot of just kind of tachycardia type issues. So on event recorders, seeing sinus tachycardia, various types of ectopy, premature atrial or ventricular contractions, a little bit of some supraventricular beats. There's reports of new onset arrhythmias post-COVID. I haven't seen those myself, but it's been reported that that can be an issue that people see. Another very common thing we see kind of deal from the neurologic or psychiatric aspect of things. So the type of symptoms these people present with are a lot of things like dysautonomia, whether that be kind of tachycardia type issues, neuropathy issues, a lot of deconditioning, which whether that's neurologic, cardiac, or pulmonary, well, it can kind of fit in all of those. The fatigue and brain fog are probably, again, some of the more common things that we see in a lot of these people. And these are usually the ones that are the most meaningful to the patients. These are the ones that are making them to the point where they aren't functioning the way that they're needing to or wanting to. See a fair amount of people with new onset headaches, anxiety, depression, PTSD from a psychiatric standpoint of things. A lot of sleep issues as well, whether that's falling asleep, staying asleep, nightmares and things like that. From a neurologic workup, there's some people who have put out their guidelines of what they do from the standpoint of workup. And some of them say everybody should get a MRI of their head. Probably a little bit overkill for a lot of these people. Now, if somebody has some focal deficits, then that's a little bit of a different situation there. But generally, don't start with MRI on these people. One of the tests I've felt has been really helpful is neuropsychiatric testing here. So a lot of these people are having that brain fog, kind of the memory issue, recall issues, where neuropsych testing can give a lot of information about what type of issues that they're actually having. And not only that, they can give some suggestions of what they can do to deal with that. We use neuropsych testing a lot for dementia type issues, which we're looking more to say, hey, is this more of an Alzheimer's type, a vascular type, Parkinson's type? Not really using it from this standpoint, but more from the memory issue of things. Issue with that is, I'm sure with a lot of other places, is getting people in there. It takes a month or two to get people in for neuropsychiatric testing. Another thing that I've used quite a bit here is our behavioral health specialist. So with our patient-centered medical homes, we have behavioral health providers embedded in our clinics. So to make a referral to them, it's very easy. You say, let's talk to Mike down the hall. So the behavioral therapist, what they're able to do, there's a lot of things they can do. They can do some of the memory type issues, so they can talk about various things that people can do about memory. Now, they're not neuropsych trained, but they can help with that, especially if it's a standpoint of getting a person in 2 months down the road. What can we do in the interim for these people? They also can help out with a lot of the psychiatric issues these people have. A lot of people who have never had issues with anxiety or depression before in their life, post-COVID, are now dealing with those issues. A lot of people have it beforehand. It's even worse afterhand. So they can work with various cognitive behavioral techniques to help out with that. Autonomic reflex testing, I've gotten that on a few people here, looking at some of the dysautonomia here. It can give you more information if you're concerned about posterior orthostatic tachycardia syndrome. All right. As with neuropsych testing, it takes 2-3 months to get people in for this. With the neuropathies that people develop with this, sometimes EMGs, nerve conduction studies, can be helpful. And again here, kind of as I talked about before with pulmonary, sleep studies for the people with the fatigue and brain fog can be a helpful test. Other things that we kind of screen for in the clinic here is chronic fatigue syndrome. So a lot of these people meet the diagnostic criteria for chronic fatigue syndrome. So as you guys know, with chronic fatigue syndrome, it's a constellation of symptoms. So it's a lot of people not being able to function the way they did before they got sick. excessive fatigue when they do things, kind of cognitive issues when they do things, unrefreshed sleep, and then potentially some orthostatic type symptoms here. The reason that's important is there's some things that have been shown to be sometimes helpful in chronic fatigue syndrome. So there are things like the SNRIs or the tricyclic antidepressants that can be used, gabapentin, pregabalin. Some of those medications can be helpful from a chronic fatigue standpoint of things. The other thing is posterior orthostatic tachycardia syndrome. So I've seen a handful of people who have really, met the, have had the testing, so the orthostatic type testing on this, where their heart rate jumps more than 30 points after standing for at least a minute, where their blood pressure really doesn't change, which can then be confirmed with the autonomic reflex testing here. Another kind of common complaint we see people with is allergies. So whether that's people had allergies before they're worse, there's some of that, but there's people who have never had allergy problems before that after getting COVID have a lot of issues there. So, kind of thinking what kind of the symptoms go along with allergy. Well, there's a lot of different things. So yes, there's, rashes, kind of flushing. You can have dyspnea, from an allergic standpoint, the itching, wheezing, congestion, hyperacidity, diarrhea, headaches, a lot of different things can be seen there. So referring these people for allergy testing, and then another test sometimes done, we do tryptase levels. So thinking of the mast cell activating syndrome. So with mast cell activating syndrome, as I kind of talked about as one of the potential mechanisms as how post-COVID happened, these are people that for the diagnosis of it, they have to have at least 2 symptoms that go along with this, which could be some of the allergic things like pruritus, rashes, wheezing, tachycardia issues, lightheadedness, GI issues such as hyperacidity, so GERD, diarrhea, different things like that. So they have to have 2 of those things. Some of the symptoms that don't count for that are part of the diagnosis, are brain fog and fatigue, but they don't count towards the diagnosis. So if you have those, that's great, but you can't use that for one of your 2. The other kind of part of the diagnosis is these people get better on antihistamine or anti-leukotriene type therapies. A lot of other issues we kind of see here, kind of ear, nose, and throat kind of complaints, really taste and smell. So this goes from it's a little bit of a nuisance to a patient, or it's to the point where the patient is now malnourished because they can't eat anything because everything smells like burnt garbage. Now, you hear that from a lot of different people. That's kind of what everything smells like. So there's a lot of variation in that. Dr. Barnes here in ENT sees a lot of people with smell issues. One of the best things that we can do for this is really smell training exercises. So how that works, well, you get various scents. A lot of times you do essential oils where you have a patient smell that for 30 to 60 seconds and kind of visualize what they're smelling to try to retrain those nerves. We see a lot of just kind of diffuse musculoskeletal type complaints here. So most people have aches and pains, not necessarily true arthritis, but more arthralgias of things. There's some reports of some autoimmune type issues, rheumatologic issues occurring post-COVID or worsening of pre-existing conditions here. Workup here, inflammatory markers can be done. Some places do these a lot more. Some places check, IL-6 levels. Now, what am I going to do with an IL-6, level? I don't really know what I'm going to do with that. But that's something to consider, saying, is there some sort of inflammation going on? What we know post-COVID, some people do have chronic inflammation. We don't know the source of it, but you check their inflammatory markers, they're mildly elevated. Imaging potential here, depending on what their symptoms might be. So imaging of ankles, knees, other joints might be helpful for these people. So kind of going back now here, back to our patient that we had, our 32-year-old gentleman. Since we left him off here with kind of this worsening of symptoms, got in actually to see a couple different specialists before he actually saw me. He saw cardiology. So cardiology, got a Holter monitor, of course got an EKG, got an exercise stress test, cardiac MRI, saw pulmonary, got pulmonary function test, saw allergy, got a tryptase level as well. So what these showed on this gentleman here is really not a whole lot. On his Holter monitor, he had some tachycardia, a few runs of SVT. His exercise stress test was normal. Cardiac MRI showed no myocardial involvement. Pulmonary function tests were normal. Tryptase was also normal. This was again his initial CT scan that he had. When it was repeated, showed that it was markedly improved. This was a few months after his initial scan. So after he saw cardiology, got put on propranolol. I think that they picked propranolol because he was having some headaches. They said, well, maybe it'll help with the headaches too, since it crosses the blood-brain barrier. Problem is that he felt awful on the propranolol and he stopped it. So somebody had ordered autonomic reflex screening, which he actually had done just before he saw me. That came back showing that he had an excessive heart rate response, which could be consistent with posterior orthostatic tachycardia or dehydration or deconditioning. So when I saw him, we talked about things here. We talked about what was done, what other kind of things might we need to do. Now this guy, again, saw a lot of the subspecialists already and had a lot of the testing done. So we discussed, talking to cardiology again about other medications for POT versus trying metoprolol. He, said, well, let's go ahead and let's do metoprolol. So we said, okay, we'll do that. We'll give it a try, see how you do. Started him on that. Now this guy, again, had been a runner before, now gets kind of tachycardic and short of breath doing minimal activity. Talked to him about seeing one of our physiatrists out at Madonna to go over what kind of things they could do there, kind of get on a good regimen to get back kind of the incremental activity. So referred him out to PMR. So saw him follow up in 3 months on the metoprolol, went and saw a PMR, got started with the autonomic rehab out there, kind of the incremental increases. In 3 months after starting this, he was back to jogging. Now it wasn't the distances he was doing before, but he's doing much better. So the question kind of arises, was it something that we did? Was it, potentially? A lot of it's time. So a lot of people that I've seen have various issues that get better with time. We don't necessarily do anything, but they do get better. So one of the issues people have is, post-COVID, is they feel isolated with things. So they're feeling horrible. They're not functioning the way that they are. They feel alone in things. Sometimes they hear from people that what they're experiencing is not real, that it's just made up in their head. So it can be definitely very tough for these people. So there's various things that they can do to try to help show them that they're not alone in this here. So there's a lot of different resources online. There's various Facebook groups. There's pros and cons of that, but that's some place they can connect with other people that are having some similar issues there. There are a lot of different online blogs and vlogs of people talking about their experiences, what they're going through, maybe what's helped them. There's a website here. It's from a group that was put together of the founders had COVID and had some of these issues afterwards, called Survivor Corps. So if you go to the website here, it pulls up. It has just a lot of different information for people to go over. So some of the acute type issues, some long COVID issues. There's a lot of webinars they have links to there. There's actually physician resources that links to, CDC stuff and some different things from that standpoint. So it's not just for patients, but again, patients can get some information here, get connected with some different resources while they're dealing with these issues. So here's just a few of my references here. And now I will open things up to questions.